the Senior Regional Director for Africa at the Center for Reproductive Rights. Thank you for honoring our invitation to the launch of the report on the impacts of COVID-19 pandemic on sexual and reproductive health services in Kenya, Burkina Faso, Ethiopia, Malawi, and Uganda. Your presence in this event is an opportunity for us to steer the wheels to ensure recovery and continuity of sexual and reproductive health services amidst COVID-19. Allow me first to acknowledge the goodwill, support, and effort of the team who carried out the study. The study was undertaken by a consortium of partners comprising of APHRC in collaboration with the Center for Reproductive Rights, Amref, Health Africa, Reproductive Health Network, NAYA, Ipas Alliance, and Planned Parenthood Global. The support of the institutions who participated in the study led to the successful completion and publication of the report. The study assessed disruptions caused by COVID-19 pandemic on SRHR. And this morning, you will all hear about the findings of the study and the recommendations that have been made by the study team. As we accelerate recovery from negative socioeconomic effects on access, availability, and utilization of quality SRH services, we must also design and implement resilient systems. With a world that is becoming increasingly globalized and issues becoming more complex and interconnected, fostering intersectional and multi-sectoral approaches will be very critical as we move forward. Today, we will hear what some of the some of the approaches and recommendations that we are putting forward to tackle some of the lessons that we learned during this pandemic. I want to take this opportunity once again to just welcome you to this event, and you will interact more with the findings when the panelists speak about what it is that we found. Thank you so much, and we now declare this officially open. Martin told me I must declare it open. Thank you, and thank you so much to the partners.
Now that this has been declared officially open, let me invite Kenneth Juma from the African Population and Health Research Center, who will just give us, an overview of what the study is, what the results are, what the key findings are, and then, we'll take it up from there.
Okay, thank you very much. I want to share findings of this wonderful study that was conducted by the consortium as has been indicated. And I want to indicate that I'm focusing on very key findings. As you well know, it may not be easy to really give the entire story, but I'm giving highlights that can allow us to have a proper discussion. And then, of course, we are fortunate enough to have the reports printed and the briefs that can help us to further understand the nuance of what we observed in the course of our study. So to begin with, looking at the participants, as has been indicated, we interviewed women and girls across the 4 countries that we went to, and in general, we can see that 67% of the respondents, the women and girls who are below the age of 30, those are the ones we talked to, and of course, a majority of participants were still in school as at the time of the survey. That also reflects on the characteristics of the people we talked to. And then, of course, about a third of the people we talked to were single or unmarried as at the time of the survey. Of course, a majority, about 60% were married, and then a smaller minority were either divorced or separated or were widowed. Of course, another smaller majority did not respond. When we look at the providers that we talked to across There are 4 countries. Of course, the study was in 5 countries, but the quantitative aspect or component only focused on 4 countries. So when you look at the characteristics of the providers, of course, a majority of them came from primary level health facilities, which is about 82%. And then, of course, a smaller minority, 12%, to a referral or secondary level facilities, and then, of course, a smaller proportion are from tertiary facilities. When we look at the professional cadre of the respondents at healthcare provider level, a majority, of course, were nurses and midwives. There were clinical officers. There were also a few specialists here and there. Now, when we now go down to what happened in terms of access to sexual and reproductive health services, as well as access to information, from the slides you can see, I hope it's bigger here, that a huge majority, and this is a summary of all countries, a huge majority, when asked about their source of information, indicated that they drew sexual and reproductive information from their friends or peers. And of course, this is not surprising because friends or peers form part of the social support. These are confidants. These are maybe close relatives. That then individuals, women and girls, are able to confide very secret and sensitive information. And of course, based on this understanding, at times studies that have attempted to understand social behavior, such as abortion, Boniface, my colleague here, knows very well. You actually can talk to social networks to understand whether women have sought abortion services or not, because most often they confide to friends and peers. And then, of course, a significant majority as well, about a third of women and girls also noted that they sought information from internet. Now, again, internet is increasingly becoming as a platform for deploying sexual and reproductive health information, most often unregulated, but we see young people increasingly seeking information from the internet. And of course, this is mainly accelerated by the fact that there's an increase in availability of smartphones. Access to internet is perhaps becoming easier, and so on and so forth. So I think as we think about how do we reach young people, internet then can never miss in that discussion. And when we break down the figures by countries, across all the countries, the 4 countries, there was consistency in majority indicating friends. It was only in Kenya where a majority of women indicated that they were seeking information from the internet. And I think it's good to interrogate that further. Another mode that was not really investigated but was reported in our qualitative studies from a lady in Burkina Faso who indicated that she relied on radio, okay, to get information about family planning. And the quote goes, yeah, if the people are talking at the radio, of course we listen. And that is good for those who do not go to the facilities, because not all women go to the health facility to seek information about family planning. Some of them rely on mass media, such as radios, to obtain that information, and I think that is key to note. Now, a woman in Uganda indicates that because of lockdown, I had to abandon using family planning, which is why I became pregnant right now. Otherwise, it was not my choice. And we know what happens when these unintended pregnancies occur. It affects both the health of the woman, the ability of the woman to live her own life. And we live in a context where unintended pregnancies, you either stay with it or you seek unsafe abortion, because access to safe abortion is, of course, restricted. And then another woman in Kenya says, I was beaten at midnight, and I was brought to the hospital at 3 a.m. The motorbike drivers were saying that there's a curfew and that there were soldiers on the road. And these soldiers don't like people walking at night. So even those with emergencies at night found it a little bit difficult to get to their portal, their points of care, because of some of those at times drastic, very broad, non-specific moves by the government to try and contain COVID. We see that a huge majority of women reported access to contraceptives as one of the biggest areas where they had challenges, followed by antenatal care, HIV/AIDS, and of course safe abortion care. Now, even a slight disruption in access to contraceptives, a slight disruption in access to antenatal care may mean a huge amount of loss in terms of maternal mortalities, newborn mortalities, child mortalities, and so on and so forth. So these disruptions, while they may look slight, but in terms at population level, they may have very huge impacts. Now, how did women cope to these barriers that they faced in accessing services? And we see there are three main ways in which the women reacted or coped. Majority of women and girls delayed seeking healthcare services. A huge majority said they delayed, they had to postpone, and yet another 22%, about 1/4, visited another health facility or healthcare provider. Now, much more worrying is about 16% of women decided not to visit a health facility at all because of the barriers they faced. And we are yet to understand in full what the impact of such decisions mean, both today and in the short term, in the mid-term, and in the future. But we know that these are grave consequences that I think will help us to think much more deeply for the future, in the event of future public health emergencies, that perhaps we need to think much more deeply about how we act and react to public health emergencies. As noted by a lady in Kenya who indicated that I decided to go to the pharmacy even though the costs were very high to buy the drugs that I needed. Now, when you look at availability of services during that time, and I must indicate that there were different waves of COVID, and the various waves of COVID had sort of not consistent outcomes. Maybe in the later stages, there was a bit of resilience that was gained over time, and so the effects were not as grave as at the beginning. However, one thing you cannot miss to talk about is that very early in the pandemic, there was stockouts of most sexual and reproductive health commodities and supplies. And of course, as reported by a provider in Malawi, stockouts are reported on contraceptive methods like emergency contraception, condoms, oral contraception, injectable implants, and IUCDs. Now, health facilities reacted as well to the context that they found themselves during the pandemic. And the reaction was mainly to try and sustain the availability of services. So some of the actions that were taken by health facilities were to train, and this was driven by both partners in the private sector and also, at the Ministry of Health, to train providers on handling, COVID-19 suspected patients. There was also, of course, even to date, several disinfection points, sanitization, provision of IEC, information education material. PPEs, of course, was an issue. And then, to a certain degree, there was total or partial cessation of certain services. Some of services that are not considered critical, in quotes, were not available. Most facilities adjusted timings for sexual and reproductive health services to ensure continuity. So what would happen is that some facilities would say, hey, so women coming for antenatal care are only allowed to come on particular days, to reduce the volume of people coming to the facility. Because some reacted by altering referral patterns. Some also introduced self-care. And when you look at the country level differences, we are happy with countries that sort of made the effort, and Kenya stands out, perhaps because of the sample of facilities we targeted. Even though there was a certain level of randomness, but facilities in Kenya are mainly supported by NGOs. So perhaps it explains why a great proportion of facilities in Kenya that we interviewed indicated that they had some level of self-care that they are trying to induce. Now, when you look at reasons why some services were not available, we have a table there, and most of facilities, because this was a question to facilities, whether they were offering these services at the time of the survey or not. When they were not offering the services, we asked them why. A majority, for instance, when you pick post-abortion care or comprehensive abortion care, reported that it was an issue of stockouts or that they lacked trained providers. So when we compared the pre-pandemic and the pandemic period, there was a general decline in uptake of services across most of the services. When you look at contraceptives, there's a decline. So the blue is the pre-pandemic period, and then The orange is as at the time of the survey, which was during the pandemic. There's a general decline in uptake of services, and of course that still reflects on what we highlighted earlier, the barriers that existed on the way of these women getting to the facilities. So except for post-abortion care and comprehensive abortion care, which had slight uptake comparing before and during the pandemic. So CAC, I think about 2%, and then for post-abortion care about 0.4%. Increase in uptake of those services during the pandemic. And as noted by a client in Burkina Faso who said there was general fear and we were suspicious. We didn't even want to go to the health facilities for fear of contracting the virus. And I think that was a dominant narrative, even in Kenya, where facilities were seen as hotspots. And people were trying to avoid facilities for fear of catching the virus there. Now, what is the take-home message? COVID pandemic and government actions against the virus, which, as noted by our keynote speaker, was actually well-intentioned to a certain degree. But these actions disrupted availability of, access to, and utilization of sexual and reproductive health services. The Ministry of Health developed policies and guidelines that enabled health providers to continue delivering services. That's taken. However, there's need to strike a balance, a very delicate balance between addressing health crises and also ensuring continuity of critical and essential sexual and reproductive health services. Now, the key recommendations could be divided into 4. At the health system level, of course, we recommend that response to emergencies need to be balanced against public health needs and priorities. None should take priority over the other. There should be a delicate balance. And then governments should ensure sustainable and resilient supply chains, because supply chain really emerged as a key bottleneck to access of services during the pandemic. So when supply chains become resilient and sort of proof to sudden shocks, then of course we can see continuity of services at the health facility. Then of course there is also need to focus on health providers during such times to make sure that they are protected through availing PPEs, and then they're also the capability of addressing their broad social and economic fears. Most importantly, sexual and reproductive health funders also need to increase their funding and support to sexual and reproductive health services, while also targeting resilient supply chains and services during crisis. At the policy level, that multi-sectoral approaches, not unisectoral approaches, but multi-sectoral approaches should be used when developing or implementing government policies and guidelines in response to pandemics. And this should be done through a collective action strategy that does not over-rely on, so we don't discount health services for security. That security takes precedent. I think there should be a key balance in these actions. Then policies and guidelines also need to be continuously reviewed in order to respond effectively to their rising realities and needs. Holistic responses, of course, and recovery strategies that consider impacts in different socioeconomic sectors, I think is important. Girls who were unable to go to school and so, lacked access to education and lacked access to services, there's need to look at them in whole and not only address access to education and nothing about, the access to services, especially in the context of the pandemic. At the service delivery level, of course, countries now need to much more strongly invest in telemedicine approaches that, of course, are able to enhance access to sexual and reproductive health services for all. Of course, and this is in line with what we target most, the universal health coverage goals, that, of course, targets access to services and coverage, and also ensuring that all these services are affordable. That the Ministry of Health also should accelerate efforts towards having self-care guidelines that are tested and implemented, and remove any regulatory barriers to self-care to ensure smooth rollout in all countries. Health facilities should also institutionalize inclusive and continuous and consistent training, client-friendly training to their providers, and sensitization of healthcare providers to ensure, again, that they are able to address the needs of all women and girls and adolescents without biases, because the harshness of healthcare providers was noted as one of the barriers to adolescents seeking services. At the community level, of course, we need to strengthen and utilize community structures, which came in handy, very, very handy. In our qualitative interviews, we we picked a case where community outreaches could reach out to girls, create networks that were empowering them or preventing, issues such as acquisition of HIV or getting married at an early age. But yet, with the pandemic, some of these measures could not be implemented, and so most girls in those groups disappeared. Some of them, of course, were married off, and so on and so forth. So there's need to strengthen the use of community health outreach and interventions to enhance access to services, but also these community structures could be effective in distribution of commodities, especially to remote villages and settings. Otherwise, the final recommendation targets vulnerable populations, that the broad and non-specific actions by the government need to be relooked next time to make sure that certain special categories of people really have maybe special passes, or that there's a provision that allows pregnant women to get facilities when they need to, and that they're not victimized or punished or forced to undress, as picked up by a case. Was that in Mombasa, Amy, where a woman narrated how the security forces forced her to undress to confirm if she's pregnant? So, of course, such experiences are well nuanced, but reflect the setting in which we were operating. And so vulnerable populations, I think, need to be looked at when addressing the pandemic issues, and that there's need to treat them as essential or critical groups or populations needing critical services, and that if an identification could be provided, then that would go a long way to ensure that they have access or easy access to services. I would be remiss if I don't acknowledge, even though they've been acknowledged, our funders to the various organizations that participated, the consortium members, and all the researchers that participated in this study, and also the respondents of the healthcare providers, the women and girls that we interviewed. I think we appraise them today. For the full report, we will be presenting it today, and that is the link. Otherwise, thank you very much.
Thank you, audience. Now, we have come to that point where we want to launch this report. We have been told what is in this report. We have interacted with it. We have been challenged to do more. And we are saying this is the beginning. We are moving from an era where we are engaging policymakers without evidence. We are saying we are going to use evidence-based decision making. And we are going to use evidence-based advocacy. And before this, all we had was anecdotal evidence of what is happening on the ground. We have gone to the ground. We now have something that we are going to use to engage the government, engage ourselves, engage the community. And now I have the singular honor of launching this in, and I'm going to ask all of you to stand up so that we celebrate the good work and the journey that we are just about to begin with this very wonderful. The researchers who are standing far away, this is your product. Please come along, come along, come along.
We'll hold this up.
Yes, 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 yes. Yes, here you go. Now it's our singular honor to declare this report officially launched. Clap for us. Thank you to all the partners and to all of you who made this possible.
Thank you.
My name is Dr. Ernest Nemato. I work for Ipas, which is a sexual reproductive health rights organization. I'm the global director for quality of care, so I cover programs not only in Africa, but in Asia, but also Latin America as well.
My name is Acheng Akumu. I'm the regional director for Planned Parenthood Global, based here in Nairobi, Kenya.
My name is Daisy Tuzo. I lead the Youth Engagement Program at Planned Parenthood Global for the Africa region.
My name is Kenneth Juma. I am a research officer at the African Population and Health Research Center.
I am Emi Kageha Igonya, a medical anthropologist at the African Population and Health Research Center.
My name is Nelly Nyasi. I'm the Executive Director, Reproductive Health Network Kenya.
My name is Evelyn Opondo. I'm the Senior Regional Director for Africa at the Center for Reproductive Rights.
My name is Ruth Mumanyi. I work at Planned Parenthood Global.
My name is Victor Arasubu. I work for Network for Adolescent and Youth of Africa as the Executive Director, and today we are here to launch a 5-country study on the effects of COVID-19 pandemic in terms of access to sexual and reproductive health and rights.
In Africa, and specifically Burkina Faso, Uganda, Kenya, and Ethiopia.
This study meant to explore and report how COVID-19 affected the lives of girls.
We wanted to see how women and girls had been affected, how access to sexual and reproductive health information and services had been affected, and what kind of data do we have to inform or help us plan for future pandemics.
Issues revolve around access, utilization, and availability of services that we presented today.
Whereas there were several measures that were put in place by governments to contain COVID-19, there were unintended consequences that affected sexual reproductive health and rights.
I think the key one is that what COVID did was make a situation that was really bad even worse when it comes to sexual reproductive health and rights.
The fact that close to 1/4 of women across the countries that we went to were unable to access these services when they wanted them is really shocking.
For example, in Kenya, over 39% of the respondents got sourced for information on the internet. Then we had relatives, friends, peers at around 36%. Then moving down, and teachers only scored 4.2%. Understand that a lot of schools were closed, but that tells you even in the integration of the online studying, then that did not comprehensively respond to the information that people needed on sexual and reproductive health and rights.
We work in Burkina, Senegal, Uganda, and Kenya, and it was uniform across that the government response was inadequate, right? And the systems are fragile and therefore denied important health rights to women, and young people in particular.
We had reports of women dying while trying to go to health facilities for delivery. We saw an increase in gender-based violence.
Women who were getting into labor later in the evening or at night were not able to go into health facilities because, for example, there was no transportation to those facilities. We also saw, that there was stockouts. So a lot of commodities, such as contraceptives, were not accessible or available to the women. Again, because issues around sexual reproductive health were deprioritized because government, invested all its resources on health towards combating or containing COVID-19.
And COVID actually compromised access to these services, and many women decided not to go to health facilities because of the restrictions and also because of fear, fear of infection.
If you look at the COVID-19 period, even budgets that were ordinarily for sexual reproductive health were diverted into COVID.
Rightly so, but both could have been done. Could have been able to control COVID, but continue to ensure, particularly women and other vulnerable populations, can still access sexual reproductive health and rights. What that means in critical terms is that women who are pregnant could go and get children safely. They could take their kids for vaccination. But importantly, those who wanted to control fertility could go and get contraceptives and do so and get the full range of choices that they needed.
There's need to ring-fence that budget so that the needs, the sexual reproductive health needs, are still addressed, even as we address COVID-19.
Also, what came out is the idea of the self-care that people used, whether it was destructive or now using it as a coping mechanism, and as well as telemedicine.
I think one of the things that has come out of COVID for all sectors is the question of how can we use technology, entrenched technology in all our approaches. And health is one of the areas where we can continue doing that.
There is need for integration of new or emerging practices around telemedicine, healthcare, and also the policies need to respond to the realities of the people, and this needs to be informed by evidence.
We need to increase accountability and ensure that these policies are implemented, and when the implementation is taking place, there is need to take into consideration human rights.
This was really important for us, you know, just to document this, to be able to plan for the future.
Yes, I think we were caught out. We should have been prepared for this. So we were caught up, we never had policies in place, because pandemics have been happening historically. This pandemic is not new.
Each of the 5 governments from within which countries we collected data, there is need to critically address the gaps and challenges that we have documented.
How do we borrow lessons from what worked in Uganda, Burkina Faso, Kenya, and be able to implement better moving forward?
And that the governments should be very, very deliberate in terms of their policy response when it comes to addressing the needs of these vulnerable groups in such situations.
So they can use the report to make the services better and to be inclusive.
When we speak about resilience, it's this ability to withstand shocks and continue functioning. So governments need to be much more resilient when it comes to the health system. So put in money, invest for the future, so that when there's a shock, the government can respond.
I think it's important that we are using evidence to inform decision making, and we are hoping that government, all these 5 governments and other governments within Africa will use this report to reflect on how they approached COVID and how they can learn from the lessons.
It is critical that the government ensures proper resourcing of sexual and reproductive health and rights within the package of responding to the pandemics, and also ensuring that there is access in terms of how do young people, those who require medical emergencies, in terms of access to contraceptions, how do they ensure that all these people are able to access services, and therefore the policy framework, the decrees and directives given must be able to look at this wholesomely and in totality.
Involve young people. We are here discussing about issues that affect young people. Young people should be in charge of their lives, so it's an avenue or an opportunity for us to integrate them. When we are creating programs for SRHR, young people should be part of these programs.
It's really important that we continue to empower young people. Young people should be able to not only access rights, but know about their rights. And that information is very powerful. We've got to counter the opposition. We've seen this global movement with regards to the opposition misinforming young people in particular about their rights, about sex. Okay, I mean sex, we want a message of sex positivity so that it leads to a healthy future as well as, sustainable livelihood.
UNFPA has actually shown from findings that every $1 you invest in sexual reproductive health and rights yields a $6 benefit for the economy, because unwanted pregnancies are averted, women can go back to work, and women can have access to other rights. So investing in sexual reproductive health makes not just health sense, but also makes economic sense.
It was interesting to do this research, and I think it should be taken seriously for way forward on how to deal with other crises or pandemics that come in place. It informs that, how you can restructure, involve everyone, every stakeholder.
And for us in civil society also, it's important for us that we are using evidence in our advocacy. And so we will be using this to engage government and various organs that have the duties of implementing these rights.
We are not going to just put it in books, but we're going to read it so that it also informs our next moves, our next planning, and even our next preparedness for the pandemic.
The partners that really worked hard to deliver this report, this is massive work, it's an investment, and we also thank the funders who supported this work, because without them, this would have not worked.